Can hear you perfectly.
Okay, great.
And then, do you know if Dr. Gross is on? Wait just a
Yes.
minute for him to get on here.
Okay. Do you
And then
want
I'll
me
just,
to get do you want me to get out of the video, the camera view?
it's up to you, whatever you're comfortable with.
No, only because you said, there was a time lag and there was a delay. Um,
Oh,
yeah, I
um,
could do that. I could just X out of this so we don't have trouble seeing the slides.
okay.
Um,
I think right now you sound fine, but maybe with the slides it'll get slower. So maybe.
right. I just, I don't want to be the one responsible for delaying things.
Oh,
I'm
no
just gonna
worries.
go with um, let me know when you want me to begin.
Sure. Let me just see really quickly if Dr. Gross can get. Oh, there he is. Okay, perfect. So I'll just give a very brief introduction, and then I'll let you guys take it away. So,
Mhm.
thank you everyone for joining the session today. My name is Hiba Sheikh. I am an intern with the Illinois Department of Public Health. So, again, I'm just going to be introducing today's speakers. So, today's speakers are Dr. Shekar. I hope I'm saying that correctly, and Dr. Gross. So first we'll start with Dr. Gross. He is the pharmacist lead for the Antimicrobial Stewardship program at the University of Illinois Hospital and Health Sciences System and is clinical associate professor at the University of Illinois at Chicago College of Pharmacy. And then we have Dr. Shekar. She's an assistant professor in the Department of Applied Dental Medicine at Southern Illinois University School of Dental Medicine, and her area of clinical practice is oral medicine and management of medically compromised patients. So we are so excited to have you both here today and are really grateful you're taking the time to speak to us. So without further ado, we will get started. So if you guys want to unmute your mic, and we will begin now. Thank you.
Thank you, Hiba. Um, Dr. Gross and I are going to be presenting on some recent updates in the management of oral infections and antibiotic prophylaxis in dentistry. The focus of my presentation is in two areas: one, antibiotic prophylaxis, and two, the management of acute dental infections. So let's begin by looking at what the problem is and why, what some of the reasons are why there's um, such a widespread indiscriminate prescription of antibiotics by us dentists. So the number one problem, I believe, is the uncertainty that's associated with just waiting and watching before you see systemic involvement or widespread infection. So the dentists want to prevent that situation and therefore prescribe antibiotics in most cases. Second is the barriers in healthcare system, the gaps in knowledge, and just a general disagreement with existing guidelines. And like we said earlier, diagnostic and prognostic uncertainties with dental infections being the number one cause. Also, the patient's expectations when they see the dentist is to come back with a prescription of some kind. So, all of this leads to an increase in antibiotic resistance, and one needs to be mindful of that. Um, So, with this overzealous use of antibiotics, what's been reported in literature is, and what's coming out of the CDC is that at least 2 million people in the US have become infected with bacteria that are resistant to antibiotics. So, that is a problem. We don't have antibiotics to treat those resistant infections, and at least 23,000 people die each year as a result of these resistant infections, and about 150,000 emergency hospital visits were reported because of these adverse events associated with antibiotics between 2011 and 2015. So that's a large number. All the more reason why we should focus on the solution, which is a robust antibiotic stewardship. And I think the first step towards that would be to shift our focus as then as from a just in case model to prescribing antibiotics only when absolutely necessary, and to first have evidence based guidelines in place and then to follow them. So recommendations decreasing the use of antibiotics either prophylactically, mainly in cases where we're prophylactically prescribing antibiotics to those with heart conditions, those who've had joint replacement surgeries, and also in therapeutics where we're managing dental pain or intraoral localized swellings. And this would include even delayed prescription of antibiotics if and when necessary. So, part one of my presentation is, like I said, on antibiotic prophylaxis before dental procedures. We'll start with the number one, which is in patients with prosthetic joints who are undergoing dental procedures that involve the manipulation of periapical tissue or oral mucosa. So, in general, the ADA guidelines state that for
Hi,
patients.
Dr. Shekar. I'm so sorry to interrupt, but it looks like if you're sharing slides, I don't think we can see them.
Oh, that's odd, because I thought that was turned on. Sorry, let me make sure you can see it.
Sorry to interrupt. It sounded like you were clicking something, so I figured I'd let you know.
I've been clicking for a while now.
Oh no.
I didn't realize. I thought I had it, turned on. Do you see the slides now?
Yes, I can see them now.
Okay. I don't want to waste time going over, what I already presented, but
Yes,
there's
and
nothing
these will be
much to it.
available tomorrow afternoon for everybody too.
Okay. Uh, okay. This is where I was. Is it the right view? Do you see it okay?
Yeah, I can see it fine.
Okay, I'm just going to keep going then.
Okay, perfect.
Uh, so in general, for patients who've had prosthetic joint implants and prosthetic joint surgeries, prophylactic antibiotics are not recommended by the ADA. And this is because dental procedures are not associated with infection of these prosthetic joint implants. Also, um, antibiotics do not prevent giving prophylactic antibiotics to your patient does not prevent any of these infections. There's also the added risk of anaphylaxis, resistance, opportunistic infections like Clostridium difficile, which is now referred to as Clostridioides difficile infection. So the benefits of prescribing antibiotics prophylactically really doesn't do the patient any good, if at all. So one needs to consider individual patient circumstances before you even consider antibiotics prophylactically for your dental patient. So the AAOS, the American Academy of Oral Orthopedic Surgeons, has the appropriate use criteria, which is a decision support tool and available on their website. So this is a guide that most dentists find useful, when they're trying to determine if antibiotics are necessary before performing any dental procedures that involve any gingival manipulation or cutting through oral mucosa. And the guidelines say that antibiotics are not recommended except in cases where there's the highest risk of adverse outcomes from dental procedure and from the patient's medical history. So this would include patients who've had a history of prosthetic joint infections, either during or post the surgery, those who are known diabetics and who have an HbA1c above 8 or a blood glucose above 200, or have an immunocompromising medical condition such as HIV with an opportunistic infection, or receiving immunosuppressant therapy for an autoimmune disease. Um, so prophylactic antibiotics should only be considered after you consult with the patient and the orthopedic surgeon. And when it's deemed necessary, the guidelines say that it is most appropriate that the surgeon recommend the regimen and, when possible, write the prescription as well. So, in general, do not prescribe antibiotics. But if you think there's a need based off of your assessment of the patient's medical history and when you're making use of the AUC criteria available on the American Academy of Orthopedic Surgeons website, then you still want to make sure that you consult with the patient and their surgeon before you have your patient take prophylactic antibiotics. In terms of guidelines for prevention of infective endocarditis, over time, over the years, the guidelines to prevent infective endocarditis have undergone a few iterations. And the EHA right now continues to recommend the guidelines that we followed back in 2017 with just some minor changes. It continues to recommend that we prescribe antibiotics to a very small group of patients or subset of patients who are at the highest risk of adverse events from dental surgery. And so the only change that this new guideline that came out in on the 18th of May in earlier this year was with the use of clindamycin. And the reason why we prescribe antibiotics to a very small subset of patients who are at the highest risk of developing infective endocarditis is because infective endocarditis is most likely is likely to develop every day with just routine activities like brushing our teeth, flossing, or even chewing food. And there's an exceedingly small number of cases, as presented in this paper, that are prevented by prophylaxing your patient before a dental procedure. So therefore, you reserve this only for patients that are at the highest risk of adverse outcomes, and the paper clearly delineates who needs to be receiving antibiotic prophylaxis before dental procedures. And like I said, the only big change was that the expert panel recommended against the use of clindamycin as an alternative to amoxicillin in those that were allergic to amoxicillin or ampicillin. And this was because with clindamycin, they found more frequent and severe reactions than any other antibiotic that was being prescribed, including C. diff infection, and they recommended alternatives like cephalexin, azithromycin, clarithromycin, or doxycycline. Interestingly, what was also mentioned in the paper was that almost 15% of community-acquired C. diff infection was attributed to antibiotics that we prescribed as dentists for a dental procedure. And the paper also states in favor of cephalosporin that fatal anaphylaxis from a single dose of cephalosporin in those patients who are allergic to the commonly prescribed amoxicillin in patients, it was less than 1 per 1 million doses, so very, very small amount. And fatal reactions to macrolides also, they reported, are very rare. However, they cautioned against using azithromycin in cardiac patients with a prolonged QT interval, and a prolonged QT interval on electrocardiogram would be one that's longer than 450 milliseconds. So those are the groups of patients that you need to be cautious with when prescribing azithromycin as an alternative. So here's a list of all the underlying conditions for which antibiotic prophylaxis is suggested in this 2021 iteration of the guidelines. Nothing's changed since 2007, so we're still recommending. They're still recommending antibiotic prophylaxis for patients with prosthetic cardiac valves, including transcatheter prosthesis or prosthetic valve material that's being used for valve repairs, including annuloplasty rings, those with a history of infective endocarditis, or patients who've had a cardiac transplant with some valve regurgitation due to a structural defect in the valve, and those with congenital heart disease, specifically only those patients who have an unrepaired cyanotic congenital heart disease or a completely repaired heart defect with some prosthetic material during the first 6 months after the procedure, or those that have had a repaired congenital heart disease but with some remaining residual defect. keep in mind that they're not recommending antibiotic prophylaxis to patients who have pacemakers or any other implantable electronic devices, any septal defect closures when there's complete closure that's been achieved by surgery, any peripheral vascular grafts, any coronary artery stents or other stents, any pledgets, any such devices or pledgets no longer warrant antibiotic prophylaxis. And like I said, this has not changed since 2007, remains the same. So dental procedures where antibiotic prophylaxis is suggested is where we're manipulating gingival tissue. So any deep scaling, root planing, manipulation of the periapical region of teeth, including root canal therapy, perforation of the oral mucosa, as with any surgical procedure. And cases where they don't suggest that we prophylax is with routine local anesthetic injections, acquiring dental radiographs, any placement or adjustment of orthodontic appliances or RPDs, shedding of teeth, and bleeding from trauma. So with antibiotic prophylaxis, a single dose of antibiotic, oral antibiotic, or intramuscular, intravenous antibiotic is recommended 30 to 60 minutes before the procedure. The most commonly prescribed is oral amoxicillin at 2 grams in adults. And if the patient's unable to take oral medication, then ampicillin is now recommended. If the patient's allergic to penicillin, here's the change. Clindamycin is no longer recommended, so cephalexin, azithromycin, or clarithromycin, or even doxycycline. Now, if the patient forgets to take the antibiotic 30 to 60 minutes before the procedure, or you forget to give it to them, you can still go ahead with your dental procedure and then give the antibiotic to your patient up to 2 hours after the procedure. If the patient's already receiving a course of antibiotics for any other reason, then you may want to consider prescribing or selecting a different class of antibiotic. And so this is part 2 of my presentation, which is the management of acute or the urgent management of acute dental pain and swelling or infection. I'm drawing heavily from this November 2019 paper, which really gives you the most recent evidence-based clinical practice guideline from the ADA regarding the use of antibiotics in the urgent management of pulpal infection. So what one needs to keep in mind is that these guidelines were drafted and published in November 2019 before the recent changes or recent recommendations on the use or recommendations against the use of clindamycin. So anyway, this November 2019 paper talks about 2 specific clinical scenarios, one where definitive conservative treatment is immediately available, and secondly, where definitive conservative treatment is not immediately available, which means you're not able to really provide treatment, including pulpectomy, pulpotomy, root canal therapy, or incision and drainage of the abscess to your patient at that visit. What one needs to keep in mind again is that this guideline does not talk about the management of adults with cellulitis or those who have who are immune compromised or those that are undergoing dental extractions. So let's look at the first scenario where definitive conservative dental treatment is immediately available. So whether the patient has symptomatic irreversible pulpitis or pulpal necrosis and symptomatic apical periodontitis, the guidelines recommend that you provide immediate conservative treatment and that you do not prescribe antibiotics as an adjunct to your treatment. You only provide treatment and there's no need for antibiotics. The third scenario would be pulpal necrosis with an acute apical abscess, but along with systemic involvement, which would mean fever, raised temperature, malaise. So any signs of systemic involvement they recommend that the dentist go ahead, perform definitive treatment along with prescribing antibiotics, either amoxicillin or penicillin. They recommend that they recommend both, but I think they say that amoxicillin is preferred, given that it is more effective against gram-negative anaerobes and is associated with fewer gastrointestinal side effects. They also recommend that you reevaluate your patient within 3 days. And more importantly, you instruct the patient to discontinue using the antibiotic that you had prescribed 24 hours after the patient's symptoms resolve. Again, in cases where if first-line therapy with either amoxicillin or penicillin fails, there's two things that we could do. One is to add on metronidazole to broaden the scope of antibiotic therapy, or you discontinue amoxicillin or penicillin and then start your patient on augmentin. In patients who have a penicillin allergy, and they don't have a history of anaphylaxis or angioedema with penicillin, amoxicillin, then they recommend prescribing cephalexin. But if the patient has a history of anaphylaxis or hives or angioedema with penicillin, then they recommend azithromycin. And like I said earlier, because this publication is from November 2019, they still have clindamycin listed as one of their recommendations. And if first-line therapy fails, like we did earlier, you can add metronidazole to cover anaerobic infection. If you're not able to provide definitive conservative treatment to your patient, you don't prescribe antibiotics as an alternative. You just refer your patient for definitive treatment if your patient has symptomatic irreversible pulpitis with or without apical periodontitis. If the patient has pulpal necrosis and symptomatic apical periodontitis, again, you don't prescribe antibiotics. You refer the patient for definitive care. And if definitive care is not feasible, then they recommend that you write out a delayed prescription of either amoxicillin or penicillin. And for the management of pain, they just recommend over-the-counter pain medications, ibuprofen along with acetaminophen. So a delayed prescription would be where you write a prescription that is post-dated, and you give instructions to your patient to fill the prescription after a predetermined period, or you instruct the patient to call and then come collect the prescription when symptoms don't improve or when symptoms worsen. That way you're avoiding what would be an indiscriminate prescription of antibiotics. However, if there is systemic involvement, then you want to prescribe either amoxicillin or penicillin. Also provide urgent referral, given that you're not able to provide immediate care. You reevaluate your patient within 3 days, and again, you want to instruct your patient to discontinue antibiotics 24 hours after his or her symptoms resolve. So the bottom line really is you do not treat pulpal pain with antibiotics. You treat pulpal pain with definitive care, be it conservative or dental extractions being the other alternative. And if the patient complains of pain, then over-the-counter pain medication should suffice. You only prescribe antibiotics when the patient's condition worsens or progresses to systemic involvement and he or she shows signs of fever and malaise. That's the only time when they recommend that you prescribe antibiotics. Thank you so much for your patience and for listening. I'll let Dr. Gross take over.
All right, can you guys hear me?
I can hear you.
Great, thanks, guys. Thanks, Dr. Shekar, for providing that overview of the optimal management of antibiotic prophylaxis as well as acute oral infections. So I'm going to kind of build off of that foundation for the talk and focus on the last two objectives for this discussion. So I'm going to be talking about some of the adverse effects that were alluded to earlier in the day of antibiotic use in dentistry. And then I'm also going to go a little bit more in depth on evaluating and managing patients with beta-lactam allergies, because as we saw, this is kind of a little bit of a paradigm shift in terms of the AHA updates and no longer recommending clindamycin. But I think, in talking with our dentist colleagues, they're interested in hearing a little bit more about how might I really assess a patient that has a beta-lactam allergy, aside from just confirming that they have one or they don't, or having a checkbox that yes, this patient has a penicillin allergy. So I'll talk a little bit about that. Again, foundational data, we've heard this before. 10% of outpatient antibiotic use is actually by dentists, and so that's why we're talking about this. And actually about 60% of prescriptions from dentists are antibiotics. And if you do a survey of the literature, you'll see that between 30 to 85% of antibiotics prescribed are suboptimal or not indicated, whether that be for prophylaxis or treatment of oral infections. So definitely some opportunity, and I think it's really important to talk about the harms of antibiotic use in dentistry, because again, in medicine, and kind of as Dr. Suda alluded to earlier, historically we've really focused a lot on outpatient prescribing in medical settings, in family medicine clinics or internal medicine clinics and things like that. And even that area is relatively nascent. And so to look at this in dentistry is even more new. And so there's not a lot of data looking at the harms of antibiotic use within dentistry. There's been like 2 or 3 large kind of national administrative databases where they looked at just adverse drug event databases that are voluntarily reported. One of these was in France and one of them was in the UK. And they were looking to see if people were having anaphylaxis, namely related to antibiotic use in dentistry. And so, they found some of that was occurring. But all of these studies that have looked at this so far have been looking at it regardless of appropriateness of use. CDI was mentioned earlier. Minnesota actually did a nice study. It was only presented in abstract form. They haven't actually had a full publication on it. But they looked at 1,600 cases of community-acquired CDI, and they went to look back to see like what were the indications, or what antibiotics those patients receive and what did they receive them for. And they found that 8% of those were actually preceded by antibiotic prophylaxis for dental procedures. So again, this is not saying it was only an appropriate use where this occurred. It was all use. But I think it's good to keep this in mind, that even antibiotics being used for a day or two can have harm associated with them. So, we kind of took it the next a step further with Dr. Suda's R01. We kind of took the next step, and we looked at what are the harms of unnecessary antibiotic prescribing for infection prophylaxis prior to dental procedures. And so basically, we used the cohort that was previously described of patients with dental visits from 2011 to 2015, using the TrueVin Health Market Scan, commercial claims and encounters Medicare supplemental database. Basically, this is an administrative database of individuals covered under Medicare and some Medicaid. And we looked at dental visits occurring within 7 days of each other, and those were considered a single episode of care. Anything greater than that, those were separate episodes of care. We included patients who had a 2 days or less supply of antibiotics, because again, we really wanted to focus on prophylaxis within 7 days before a dental visit. Again, trying to really define something using an administrative database that is probably representative of prophylaxis. And we focused on inappropriate prophylaxis. So at the time, we used the current AHA guidelines for prophylaxis indications, and we did not consider prosthetic joints as appropriate use for prophylaxis in individuals who did not have an underlying cardiac comorbidity that would put them at increased risk for an adverse consequence should endocarditis occur. We excluded patients with any hospitalizations or extraoral infections within 14 days prior to the dental visit date, again, trying to focus on those antibiotics for prophylaxis only. And we looked at the cumulative incidence of any serious antibiotic adverse event within 14 days after that prescription. That was our primary endpoint. So that was a composite endpoint of anything including allergies, anaphylaxis, C. difficile, or any emergency department visits. The secondary endpoint we looked at, we were comparing the actual occurrence of these adverse effects between different antibiotics. So amoxicillin versus clindamycin was the chief comparison of interest. We were doing this based on ICD-9 and ICD-10 codes. There was a small portion of the study that did include ICD-10 codes based on the times that our patients were included. And then we defined our ED visits based on coding from Truven. And so we had 168,000 dental visits with antibiotic prophylaxis. 80% of those actually were unnecessary antibiotics. And this is, again, that data that Dr. Suda mentioned. And so this comprised our denominator. We had those 136,000 visits with unnecessary prophylaxis. And so of those, actually, 1.4% of patients experienced a serious adverse antibiotic event within 14 days after that prescription. So that's a pretty small number, in absolute terms. But I think 1.4% is still very significant. When you look and see what was actually contributing these to that 1.4% rate, ED visits were the most common contributors with 1,600 events, followed by allergy with about 320 events. And then most infrequent were also probably, potentially arguably, the most severe: C. difficile infection, anaphylaxis. These things can be life-threatening. And so we saw those, but they were infrequent. And then our secondary endpoint, comparing the rates of adverse event, comparing clindamycin to amoxicillin, we found clindamycin to be associated with increased risk of an adverse event, which is similar to previous data that have been found. There's a study in CID from Shahab and colleagues that looked at common antibiotic classes for patients presenting to the ED for, drug-related events. For example, and clindamycin was more commonly attributed to those than beta-lactams, for example. So that wasn't too surprising. There's some limitations of these data. This is an administrative database, so there's always potential for misclassification. The ED visits that we included, we didn't have the ICD-10 codes, for example, ICD-9 codes associated with those, so we can't attribute those specifically to an adverse event per se. This denominator also really, included commercial dental insurance only, actually. I might have misspoke earlier. And then there was no comparator group either. So, definitely some limitations, but this is really the first look at, potential harms associated with unnecessary antibiotic use. And I think it's important to look at these because, again, I think a lot of times perhaps our dentist colleagues may not see some of the adverse consequences that might occur, a week or two after being exposed to an antibiotic, for example. And so I think having these data and, showing that, hey, 1.5% of patients might have an adverse event due to inappropriate prescribing, hopefully that can be a little enlightening. And so that kind of brings me to kind of the next subject here, and it kind of relates again back to clindamycin. And so JAMA Internal Medicine, they have a nice kind of series that they were doing for a little while called these Teachable Moments. And it's basically a case report, and it would be, some case report related to something that, we can learn from as clinicians. And so this was a case report actually about an otherwise healthy woman that was at 39 weeks of gestation, that was admitted for a C-section. She had penicillin listed as her allergy, or under her allergies. At the time of her operation, the reaction was unclear, but she received clindamycin instead of cefazolin, which cefazolin is the standard of care for this procedure. It's most effective agent. But she had that allergy to penicillin, so she got cleaned up. Fine, mother and child were discharged without complication, but 2 weeks later, mother comes in with diarrhea and was diagnosed with C. difficile. Based on this transition, you might have anticipated that's where we were going with this, unfortunately. So she was treated successfully. This resulted in a hospitalization and C. difficile infection, but she got treated successfully. Unfortunately, 3 weeks later, she was hospitalized again for similar symptoms and had to receive another course of oral vancomycin for the treatment of C. difficile. So this is pretty bad. Then finally her allergy was clarified, and it was reported that she had a red rash after receiving amoxicillin as a child. Okay. And so I think this, illustrates a few things. It illustrates the risk of C. difficile with clindamycin. It illustrates the importance of clarifying a beta-lactam allergy and not just stopping at penicillin allergy, let's use an alternative, right? Because the other thing here is, okay, how do we interpret a red rash after receiving amoxicillin? Would that truly have precluded using cefazolin for her procedure, right? And so we're going to talk a little bit about, the nature of these allergies that occur, and kind of help answer some of these questions that you might have. So there's some key points here. Beta-lactam allergies are very common. Up to 10% of hospitalized patients are going to have a history of penicillin allergy. It's probably similar. Maybe it's a little bit less in dental clinics. Frankly, that might be an opportunity to characterize, what is the frequency of penicillin allergy in dental clinics right there. But in our hospitalized patients, that's the rate. And the vast majority of these are non-severe, okay? Now, we don't want to minimize the significance of these unless we do a thorough allergy history, right? Because we can have very severe reactions to our penicillin, to our beta-lactams. And so the issue here, though, is these beta-lactam allergy labels can harm patients because there's been many studies, not necessarily in the dental setting, none that I'm aware of for sure. I'd be very surprised if there were any. But in medical settings, though, there's been multiple studies showing that these allergy labels harm patients because we use less effective therapy, for example, less effective therapy for prophylaxis prior to surgical procedures, or less effective therapy for acute infections on the inpatient setting because we use agents that don't have as broad a spectrum of therapy, for example, or have more toxicity. So these harm patients. So we really got to clarify these, and we have to ask clarifying questions related to the nature of the allergy. And so I'll talk about some of those as we go through this, because the responses you get to those questions are going to inform how you proceed in terms of what agents you choose as an alternative, if you even go to an alternative, because you may not. Depending on the setting you're in, whether that's a medical setting or outpatient setting or dental clinic, that's of course going to impact how you proceed because, if you're in a hospital, you might be able to do some of these other things very quickly, like graded challenge, penicillin skin testing, allergy consult. But, I would expect in a dental practice, most of these things won't be immediately available. Perhaps it could be an opportunity for referral though. And then I'll touch on briefly cross-reactivity between agents and what drives those reactions. So again, just as a matter of underlining this, this is the major change in the AHA update that came out a month or two ago. In patients who have an allergy to penicillin or ampicillin, the recommendation is not to use clindamycin anymore. Okay, super important. A lot of C. difficile, as we saw, in terms of adverse events with clindamycin, even with single dose. So we shouldn't be using that any longer. Definitely an underline there. Okay, and so as an alternative, they're saying Keflex, Zithro, Chlorithro, or Doxy. Okay. Now, there's that clindamycin recommendation. This footnote here, cephalosporins should not be used in an individual with a history of anaphylaxis, angioedema, or urticarial reactions with penicillin or ampicillin. Okay. Now, I think if you're not familiar with what exactly are the examples of an anaphylactic type reaction, or what exactly are examples of an urticarial reaction versus a maculopapular rash, for example, you might be scratching your head a little bit and be wondering, should I be really avoiding Keflex or not? Because frankly, Keflex is probably going to be better than azithro or doxy if you can use it. So we'll talk a little bit about that. And so, anaphylaxis, we'll talk about that in the next slide. Angioedema, of course. So angioedema is basically throat swelling, lip swelling, any oral swelling that occurs. This can happen fairly quickly after receiving the offending agent. Urticaria, I'll show you some examples. And then severe cutaneous reactions, we'll talk about those as well in the next slide. So that includes like toxic epidermal necrolysis, Stevens-Johnson syndrome, DRESS, which is like basically a systemic syndrome with eosinophilic reaction and end organ involvement as well as a rash, and then acute interstitial nephritis. But when we're asking these questions, it's not kind of a binary, do you have any allergies? Yes, no, or, and what is the agent? It's what is the specific agent? Okay, was it penicillin that you received, or was it amoxicillin? Or was it a cephalosporin? What was that reaction? So did you have a rash? If so, what did that rash look like? I'll show you some photos in a couple slides. How long did it take for that rash to occur? Was it within an hour or two of receiving the agent? Or was it a couple days after receiving that agent? When did it occur? Did it occur as a child? Or did it occur last year? And then did you receive other beta-lactam since, right? Like other things like other cephalosporins, Keflex, cefuroxime, amoxicillin, etc. And then how do we handle unknown reactions? Because it certainly happens that, frankly, when we're clarifying these things on the inpatient side, probably a quarter of patients are like, I don't know. My mom told me I had a reaction. I don't know. I've avoided penicillins, my entire life, whatever. So how do we handle those? Frankly, if it's an issue where a patient says, I don't know what happened. It happened as a child, and I'm 60 years old now, or something like that. Most of the time, frankly, patients are probably going to be safe. I think a key clarifying question there is, did you have to go to an emergency room because of this reaction? Do you remember any of that circumstance? If the answer is no, and they were 5 or something, they probably would remember the emergency department. You could ask that specific question. If it's not, even if they had a simple kind of rash, an urticarial rash, which is an immediate reaction, but even if they had that, chances are, they would have lost those antibodies because most patients actually over the period of 10 years will lose those antibodies with those urticarial reactions. So these are some of how these rashes might present and kind of what they look like. So the IgE mediated, this is a type 1, more severe, more immediate type reaction. And so typically these are going to be, what we call hives, right? They're going to be raised. Okay, you can see it's raised here. They're going to be itchy, so they'll be pruritic. And typically these have a rapid onset. So again, within a few hours after taking the agent. And oftentimes they're going to go away pretty quickly as well after stopping the agent. Okay, so those are kind of the hallmarks of urticaria. These are type 1 type reactions of the more severe type. So, I'm interested when I hear somebody has this, I'm interested in knowing when did it occur. If it occurred greater than 10 years ago, that's much less risk, and I'd be willing to retry an agent, especially an agent that has a different side chain, and we'll talk about that. Benign T-cell mediated. So these are things that are less severe because, they're not an immediate type 1 type reaction. They're T-cell mediated. So these occur, they take a little bit longer to occur after being on therapy. Not itchy, going to be diffuse. You can see they're oftentimes not raised. And so these are usually less severe. Sometimes on the inpatient side, we'll basically just continue the agent if the patient has a couple days left. Not as big of a deal. However, probably the most severe, arguably, of the ones I've listed here on the screen are the severe T-cell mediated severe cutaneous adverse reactions. So those are the things I was mentioning with all the acronyms: Stevens-Johnson syndrome, toxic epidermal necrolysis. This is where you have severe blistering and peeling of the skin sloughing, skin desquamation. It can involve mucosal, the mucosa, the eyes, lips, etc. And so this one you're definitely visiting or having to be handled in an inpatient facility for these reactions. Sometimes they're so severe you have to go to a burn unit. So these are things you absolutely need to be extremely afraid of, and never trial another beta-lactam for any patient that has any one of these reactions. Okay, very significant. And then anaphylaxis. So, this is a very nice table, and I'll refer you to this very nice review article that came out. It was originally actually going to be kind of a guideline, kind of a consensus guideline, but because of the nature of gaining consensus around it and the logistics with the multiple societies that were kind of involved, it ended up being kind of an endorsed review article that had input from multiple societies. But this, nonetheless, it's a very nice review for anyone that wants to kind of look into this more and have a practical, pragmatic advice to approaches for allergy, but for beta-lactam allergy specifically. So this is where I got this from. And basically, they're saying that anaphylaxis is likely when one of the three boxes here is fulfilled. Basically, patient has an acute onset, again, anaphylactic type reactions occur very quickly after exposure of, skin, respiratory compromise, shortness of breath, bronchospasm, etc., or has syncope, incontinence, etc. Or they have two or more of these. They have, involvement of the skin and mucosa rapidly after exposure to an allergen, and respiratory compromise, or one of these other things. And then the other one is any exposure that occurs within minutes to several hours that causes hypotension. Okay, so these are all signs of anaphylaxis. So any one of these three boxes, and you would classify that as anaphylaxis. And for patients that have anaphylactic type reaction, we're generally not going to be retrying any of our beta-lactams, okay? And that's basically what the AHA guidelines are recommending. Don't do Keflex if they've had anaphylaxis to a beta-lactam. Just use azithromycin or doxycycline, okay? And how do you implement these things, right? This is going to require some education, and discussion among, within the dental practice that you want to work to implement these changes in. One thing potentially, if you have the resources and ability, maybe it can be integrated in the electronic health record. This is an example of something that you can do in Epic, for example. Naturally, the electronic health records have greater heterogeneity, I think, and maybe we don't have as much resources to implement these type of things. But perhaps if you're as part of a large dental network and share a health record, perhaps you can get buy-in to implement something like this. Otherwise, perhaps just an intake, you could have these questions at patient intake or similar questions that'll help you risk stratify the patient to really determine, all right, what is the nature of this patient's allergy, and what should my approach be? Can I just give them our standard prophylaxis, or should I use Keflex, or should I be using azithro or doxy? So this could be a starting point, and it could be an opportunity to kind of make a systematic change. I alluded to side chains. So not to get too heavy into medicinal chemistry, but basically there's a beta-lactam structure, right? And so this is why, penicillins, cephalosporins, carbapenems, why they're all similar is this beta-lactam structure, this beta-lactam ring. Now, within the beta-lactam ring, there's molecular chains that come off that beta-lactam ring. There's two sites, the R1 site and the R2 site. And those chains and the molecules off those chains those are what we think to be the primary contributors to beta-lactam cross-reactivity. Or to put it another way, this is what can help predict if a patient has a reaction to penicillin, for example, what the likelihood is that they're going to react to another specific beta-lactam like cephalexin, like ampicillin, etc. And so these red highlights, and this is, again, I'll point you to this. This is another very nice review article that has this chart in it, as well as some more molecular chemistry kind of background. But if you want to go look into this, I would just refer you to this. But if you can see here, if the patient had ampicillin, an allergy to oral ampicillin, for example, Keflex shares the exact same R1 side chain. Okay, so it's the same ring structure that leads to that side chain, as well as the identical side chain itself. So this is going to have the highest risk of cross-reactivity. These ones that have just an R1 prime or lowercase r1, these have differences within the ring that leads to that side chain, or the side chain that makes it not identical, or it's just structurally similar in the case of the lowercase r1. So those are lower risk, but still some risk. And then the ones that are blank have a completely dissimilar structure, and it's not identical either. So anyway, reference for your food for thought. All right, so we're running out of time here a little bit. So some takeaways, antibiotic use in dentistry is not completely innocuous. There's been data showing that antibiotic use in general in dentistry has adverse effects, but of course, we should be using antibiotics in dentistry, as Dr. Shekar pointed out, for the appropriate indications. And we should be avoiding it where it's not appropriate, especially because of these adverse harms that we want to avoid. And so keeping these things in mind, educating our patients around them, I think is super important, and informing them of the risk-benefit. Being like, this antibiotic, it's not going to improve your dental pain, for example. You don't have systemic signs of infection. You don't have a fever. You don't have extremely diffuse swelling, etc. And so maybe we're going to withhold that antibiotic because there's some potential harms, and take this other approach. And so I think highlighting the adverse effects is important. And then, clarifying these beta-lactam allergies, because again, we want to use the most effective agent. Most of these beta-lactam allergies are non-significant, but we really want to make sure we're catching the ones that are significant and using appropriate alternatives like azithro or doxycycline in the case of severe allergic reactions like anaphylaxis, angioedema, or those severe cutaneous reactions. So definitely clarifying those beyond just figuring out if they do have an allergy, and avoiding clindamycin. And so with that, I'd like to acknowledge my colleagues over the years, Dr. Suda, who's really been a huge researcher in this space, Drs. Rowan and Hannah over in the College of Dentistry, who you're going to be hearing from next, and what's new in the dental stewardship program there, as well as other investigators and collaborators. So with that, I think Dr. Shekar and I will take, we have a few minutes for questions. Feel free to put questions in the chat or unmute yourself. There's not a huge group here.
Sorry, it sounds like there's a lot of background noise. Okay, it seemed to have stopped. And thank you all for your presentations. They were amazing. I got to watch most of it, so thank you. And again, we do have about 5 minutes left, so if you can think of any questions, please put them in the chat, and hopefully our speakers can hang around a little bit to answer those. And then just a reminder, we do have a 10-minute break after this. I'm not sure if Hiba is able to unmute, but I did see a couple of questions from Katie Suda. She asks, please clarify what the AAOS and ADA guidelines and the chair-side guide recommend based on evidence versus the AAOS appropriate use criteria statement based on rating cases, not based on the evidence. And that was kind of a mouthful, so hopefully you guys can also see the chat, and that's a response under one of Hiba's comments earlier. Did you need me to repeat that?
No, I can see the comment.
Oh, perfect. Perfect. Did you or Dr. Gross want to take a stab at answering that?
Sure, yeah. I can take Dr. Suda's question if Dr. Gross is okay with that.
Yeah, absolutely. Sure.
Thank you. So the AOS and the ADA are on the same page in terms of what they recommend. So in general, they do not recommend prophylaxis for those with a prosthetic joint implant. So the prosthetic joint may be a knee, maybe the hip, but in general, those patients that have had an implant, they do not recommend antibiotics. The only situations where they make a definitive recommendation is, so I'm trying to look at your question, and I'm wondering if, okay, so there is no recommendation for antibiotics, period, according to prophylactic antibiotics, according to the AAOS and the ADA. The appropriate use criterion that's on the AOS website is simply a guide. So if you use the appropriate use, if you use that tool, and if you key in the number of years it's been since the patient had, so one of the questions on that tool is how long has it been? Is it within a year that the patient had joint replacement surgery? And like I said on my presentation, if the patient is a known diabetic with an HbA1c above 8, it tells you that, it tells you whether the tool recommends, considering antibiotics prophylactically for the patient. It does not tell you exactly what to do. The decision would still be with the dentist. However, the ADA says that you should only consider asking your patient to take prophylactic antibiotics after you speak with the orthopedic surgeon and the patient. So one of the questions that you want to ask the patient when you're eliciting a medical history is, when did you have the joint replacement surgery? Were there any complications or infections associated with it? Does your orthopedic surgeon recommend that you take antibiotics before you get a dental procedure done? So it kind of, puts the onus on the orthopedic surgeon entirely. And that situation would only arise when you feel, based off of your assessment, whether or not you're using the appropriate use criterion tool, that your patient would benefit from pre-medication with antibiotics. I hope that answers your question.
Okay, my clock is showing 3:35, so I believe it is time for our break. Thank you all for joining this session. Take 10 minutes, stand up, stretch, do whatever you need to do, and we will see you back for the last set of afternoon breakout sessions.
Thank you.
Thanks.
Thanks, everyone.